safhada çalışılmış. Quercetin'in mucize molekül olarak değerlendiriliyor. Çok ciddi bir immun modülatör. Bununla ilgili diyabet, tansiyon, kanser hastaları üzerinde ciddi bir çalışmaları var. Covid-19 ile beraber antiviral etkinliği kanıtlandı. Ve en son çok ilgimi çeken bir çalışma olarak analjezik etkinliği üzerinde de bir çalışması var Quercetin'in. Biz de geri çalışmamıza dönecek olursak 2-atisito kompleks nedir? 2-atisito kompleks bu size anlattığım moleküllerden oluşan bir kompleksi verilmiş bir isim. Görüldüğü üzere belli oranlarda karıştırılmasıyla elde ediliyor bu. Mililitresindeki 3,42 gram gibi. Buradaki işte karabarmet çiçeği 3,14 gram gibi mililitresinde saflaştırılarak elde ediliyor. 2-atisito kompleks patentli bir ürün. Takviye edici gıda olarak onayı vardır Gıda ve Tarım Bakanlığı'ndan. 10 mg içerisinde 3000 mikrogram 2-atisito kompleks bulunmakta. Kullanım şekli ise 3x2 ölçek şeklindedir. 2-atisito kompleks ile ilk bizim tanışmamız COVID-19 hastalarında böyle bir molekülün olduğunu ve bunun COVID-19 hastalarında kullanılabilir mi diye bir yola çıktık ve makale olarak yayınlanan bir klinik olarak ispatlanmış etkinliğini sunmak istiyoruz. Yola çıkarken dediğimiz gibi 2-atisito kompleks şurubun COVID-19 hastalıklarında takip edilen klinik, laboratuvar ve PCR negatiflik süresi üzerinde etkinliğini test etmeyi amaçladık. Tek merkezli, prospektif, randomize kontrollü bir çalışma. Bu COVID-19 PCR pozitif tanısı alan sağlık personelleri çalışmaya dahil edilmiştir. Çalışmamızın da etik onayı Atatürk Üniversitesi'nden alınmıştır. Çalışmamızda Eylül 2020 ve Eylül ve Aralık 2020 tarihler arasında enfeksiyon hastalıkları polikliniğinden alınan PCR testi pozitif çıkan 150 hasta çalışmamıza dahil edilmişti. Bu 150 hasta tamamen sağlık çalışanlarının oluşmakta idi. Çünkü o dönemdeki ulusal rehberimiz ancak buna el veriyordu. Çünkü 7 gün sonrasında bir PCR testi normal halktan alınmıyordu. O yüzden 7 gün sonra sağlık çalışanları eğer PCR testi negatif ise işlerine dönebiliyordu. O yüzden çalışmamızı dizayn ederken sağlık çalışanlarını aldık. 75 hastaya o zamanki Sağlık Bakanlığı'nın uyguladığı rehber doğrultusunda tedavi planlarken diğer 75 hastaya ise 2-atisito kompleks tedavisi eklendi. Uygun bir şekilde bilgisayar programıyla kime ne verileceği randomize edildikten sonra. Hastaların laboratuvar parametreleri, klinik seyre, PCR'ın negatifleştiği ilk günler karşılaştırıldı. Çalışmamızda daha önceden bilinen bir komorbiditesi olan oda havasında arter kan gazında PO2 bölü FiO2 oranı 300'ün altında olan hastalar ve 2-atisito kompleks içeriğinde herhangi bir alerjisi bulunan hastalar dahil edilmedi. Sonuçlara bakacak olursak her iki grubunda aldığımız hastalardaki yaş ortalamamız benzer. 2-atisito komplekste 30 iken kontrol grubunda 29. Hastalar %53'ü 2-atisito kompleks grubunda %53'ü erkek iken kontrol grubumuzda %57. Bu da çalışmamızda yaş ve gruplar arasında bir istatistiksel bir fark olmadığını göstermekte. Bizim asıl çalışmamızla ilgili vermek istediğimiz tablomuz burası. Şimdi bu tablomuzla ilgili özellikle birkaç tane noktamız var. Özellikle lenfosit sayısı. Lenfosit sayısında anlamlı bir şekilde 5. günde kontrol kanları alındığı zaman anlamlı bir şekilde yükseldiğini, başvuru anında 815 iken bunun 1238'e yükseldiğini, kontrol grubunda ise benzer 785'e 938 olarak benzer kaldığını görmekteyiz. Lenfosit sayısının anlamlı bir artışı var ve asıl bizim açımızdan önemli olan tespitlerimiz SRP, D-dimer ve ferritin. Neden bunlar önemli? Bu dönemde bizim Covid dönemine daha çok hayatımıza giren sitokin fırtınasına doğru bir gidiş anlamı taşıyor. SRP'leri 38'lerden 5. gün 10'lara düşerken kontrol grubunda 14 olarak tespit edildi. Bu da istatistiksel olarak anlamlı idi. D-dimerlerimiz 995'ten 217'ye düşerken bu grupta 376'da. Ferritinimiz 794'ten 280'e düşerken kontrol grubunda 796'dan 314'e düşmüştü. 2-atisito kompleksimiz 5. gün kan tablosunda anlamlı derecede bizim için önemli olan parametrelerde düşme sağlamıştır. Klinik olarak da iki ateşli kompleksi değerlendirme için çalışmamızda devam ettik. Ateş şikayetleri, iki ateşli kompleksi 64 hastada varken kontrol grubunda 69 hastanın ateş şikayeti vardı. Ateşin devam ettiği gün sayıları bu yanda yazanlar. 3.2 gün ortalama ateş iki ateşli kompleks grubuna devam ederken kontrol grubunda 7.4 gün gibi üst bir sayıda, kat kat bir sayıda etkinlik iki ateşli kompleks tarafından gösterilmiş. Baş ağrısı olarak bakarsak yine benzer hasta gruplarında çalışılmış. 2.4 gün ve 3.2 gün gibi yine istatistiksel olarak anlamlı. Halsizlik iki ateşli kompleks grubundan daha kısa sürede geçmiş. Tat koku kaybı, ek kas, eklem ağrıları da aynı şekilde iki ateşli kompleksimiz daha etkin bulunmuş. O alan grup. PCR pozitiflik süresi burada 7.1 sayısı var. Çünkü Ulusal Sağlık Bakanlığı tarafından belirlenen COVID rehberinde sağlık çalışanlarının 7. günde test yapılabiliyordu. Bu 7. gündeki teste göre biz baz aldık ve PCR'larımız o yüzden ilk 7 gün yani çıkıyor. Kontrol grubunda ise 9 gün. Yani PCR pozitiflik sayısında da anlamlı bir düşüş sağlamıştır. Klinik çalışma sonrası biz bu çalışmayı kendi ilimizde ve bölgemizde ciddi anlamda herkese uyguladık. Ben kendim de evde böyle kendimi kötü hissettiğim zamanlarda kullandım. Zeynep hocamız COVID olduğu dönemde kullandı. Biz bu hastalarla ilgili valimiz, hani Erzurum valisine, Erzurum Belediye Başkanı'na, İl Sağlık Müdürü'ne ve birçok işte genel müdür seviyesinde iyiliğin önde gelen kişilere COVID olduğu zaman ciddi anlamda kullandık ve ciddi anlamda bununla ilgili geri dönüş sağladık. Kendileri de bize her seferinde bununla ilgili çok teşekkür ettiler. Özellikle bu tam ilk pozitif çıktığı andan itibaren ciddi bir kullanım indikasyonu doğdu. Bu konuyla ilgili ciddi, olumlu geri bildirimlerimiz oldu. Çalışmayı yapan arkadaşlarıma da bana destek olan teşekkür ederim.
Evet. Abdullah Hocam biz teşekkür ediyoruz. Gerçekten COVID dönemine damga vurmuş bir ilaçtı. Ben kendim COVID olduğumda kendime ve aileme kullandım. Birçok hastamızda da Abdullah'ın söylediği gibi içlerinde işte yakinen tanıdığımız insanlar vardı veya bir takım nedenlerle bu ilacı başladığımız insanlar vardı. Çok olumlu geri bildirimlerini aldık. Gerçekten buradaki bundan da önemli bir yayın çıktı. Buradaki tecrübemiz çok önemli. İnşallah ilaç sadece COVID'de değil, immünitenin güçlendirilmesini istediğimiz birçok durumda bize destek olacak diye düşünüyoruz. Ama COVID'in güncelliğinde ciddi mahiyette bir deneme imkanımız oldu, ciddi bir tecrübemiz oldu. Bu anlamda hem Almedico ilaca teşekkür ediyoruz. Bu geç saatte buradayız, hepimiz bu ilacı konuşuyoruz. Hem de Abdullah Hocama değerli katkılarından dolayı teşekkür ediyoruz. Sağ olunuz.
Soru veya katkısı olan yok herhalde. Tamamdır.
Soru veya katkı yoksa kapatabiliriz oturumu. Teşekkür ediyorum.
To the third day of the Scientific Session Congress, EPAT. On behalf of the EPAT Scientific Committee, I welcome you all. And it's my pleasure to introduce you Dr. Zeki Atlesi. He's an emergency physician from East Sussex Healthcare, NHS Trust. He'll be speaking about point-of-care ultrasound in shock. Over to you.
Good morning, everyone. Thank you, Sernat, for a nice introduction. It's a little bit early on a Saturday morning. I hope you are enjoying yourself as much as I do, as we do. I am delighted to be here, in my own home country and in Antalya, in a beautiful place. And I would like to thank, obviously, to our president, Professor Bashar Jander, and his team, to invite me here and to organizing such a Such a beautiful event again after all this COVID issues and challenges. I have to start because we have got very little time. I've just been asked to talk about ultrasound, using ultrasound in basically undifferentiated shock. My name is Zeki Ateş, as you can see, and as my name suggests, I'm originally from Turkey, but I left Turkey about 40 years ago and went to Germany to study medicine and then worked there. And after that, I went to England to learn English, and then I stayed there because of basically creating a family. Thus, the place is Eastbourne District General Hospital. That's the place where I work. It is a smallish hospital, but we see around 300 patients a day. And but we have got 3 hospitals under the umbrella of the East Sussex Healthcare Trust. Eastbourne is a place where basically this resort that we get lots of pensioners and elderly people in summer. For us, is also summer is a high season, not just winter. And the beachy head in Eastbourne is very famous for, like, a suicide spot. And that's the place where I live, is Brighton. It's on the south and on the coast, just very close by London, and it's called London by the Sea. What the objectives are about this ultrasound, using ultrasound in undifferentiated shock in emergency room or obviously in critical care. And what we will do is just mainly talk about the protocols, and I will just give you highlights of the most used protocol or modules. And I would like to declare that I don't have any conflict of interest. I show you just the causes of shock. And this slide is a very busy slide, just showing basically that different types of shocks. It's not always easy to find out what kind of shock is basically the case with your patient or with our patient. And sometimes this basically type of shocks can be together, coexisting, and that makes life much, much easier. As we know that what we used to do it in the past, someone hypertensive, we put an IV access in, 2 liters of IV fluids, and off you go. And we know now, obviously from the experience in the last few decades, that it can be pretty lethal and harmful for our patients. This slide is, again, as in a very busy slide, but they're the shock protocols. There are lots of them there. Since 2000, there are lots of shock protocols that come out. And mostly used is now so-called rush protocol. And I'm just going to talk about rush and variation of it. And rush is basically standing for rapid ultrasound in shock and hypotension. That was created also by Scott Weingart, who's an American emergency physician. And the principle was mainly about 3 steps, talking about the pump meaning the heart, and the heart of everything. And the tongue is meaning the chest cavity, abdomen, and pelvis, also including IVC as basically a tool to have a look if the tank is full or empty. And also the pipes meaning the vessel, and the main vessel is obviously the aorta, maybe the cause of the shock of the patient, and looking for DVT. And I just want to show you just a variation of it. It's exactly the same thing. Maybe it may be confusing, like pipes and pump, tank, and pipes. There is a mnemonic, is so-called high map. That's what exactly does the same thing. Heart, IVC, M for Morrison's pouch, meaning basically fast and looking into abdominal cavity, and pulmonary. Pulmonary meaning is the lung. On this is just mnemonic. There's a pulmonary with the lung, but is on the bottom. It actually should be on the top in the connection with heart, but in combination with just as a mnemonic, just basically to remember maybe high map. Basically, what do? We look at the heart at the center of everything if we assess a patient, because at the end is the heart, is the organ, is delivering oxygen and improving oxygenation and perfusion of the tissue. And therefore, it is one of the most important steps of our using the shock ultrasound or the integrating ultrasound into patients with shock. Here we are looking for, obviously, mainly in the left ventricle, the contractility of the left ventricle, just to see what the left ventricle does, the size of it. And then we are comparing the size of right ventricle with the left ventricle. And obviously, we are looking for pericardial effusions, meaning maybe it could be a cardiac tamponade. And that's mainly the points we are interested in. What do you think about this heart? Is it doing okay? When you look at on the right-hand side is the left ventricle. Is it doing all right or not? It's basically, it's in a poor function of left ventricle. What we are looking for is really, is it good or bad? You know, just especially when you start as a novice, just to focus on the basics, and then you just like, is it good or bad? That will give, basically, you can then integrate this information into your clinical judgment and find out what the problem is with the patient. What I do is always, when I do heart and lung together, basically I'm not going like, you know, I'm going high map down and then lung at the end. No, just the heart and lung, and that goes along very nicely because it's so interconnected. Basically the heart, then while you are doing subcostal window, look at the IVC and come back to the chest while you are looking what the problem is with the lung. What we see is that was basically so-called B lines, very wet lung. There was a patient in acute heart failure with pulmonary edema. Here is a patient, that was a patient with cancer and big pericardial effusion. And as it says, PE, it doesn't mean pulmonary embolism, but it's just basically pericardial effusion. And that's in the clinical context, but this patient was absolutely shocked. There are other signs and other views, but because you have got this picture and then you've got a clinical picture in front of you, and then you make the judgment and do the good things about ultrasound. You can use it for your basically procedure, especially if you want the pericardial centesis, and ultrasound is a beautiful gadget to help you with that too. And what we are looking at the heart is, another thing is the size of the right heart, looking for right heart strain. That was a patient that was 56 years old, and so that should play. I'll just show that one here then. The second view, that's of the heart, as you can see, the left ventricle is in D shape, meaning that basically the right ventricle is dilated, is pushing the left ventricle, and that it just takes the shape of D, meaning that the pressure on the right heart is huge. In acute settings, obviously, then we put all these things together and thinking this patient has got massive PE. That patient we had we thrombolized because of the settings without the CT. After the heart, we just while we are doing the heart, we're just looking at the IVC, looking if is it full or empty. Anything between, again, we just take it cautiously, and if it is empty, obviously, then you can see the causes. It can be basically hypovolemic or distributive. And if it is big, and then that could be cardiogenic or obstructive like a PE and tamponade. There are two pictures of IVC. On the one side is the empty, very small and collapsing fully, and the other one is large IVC. Again, then you put that in clinical context and with all your other imaging and investigations and use it to your advantage to make the right decision. Morrison's pouch, meaning basically just doing the application of fast, what I call it basically, when you look at the chest and lung, just go to the next big cavity, which is the abdomen. When you look at the abdomen, just use your fast skills if you have got it, and then you start best on the right upper quadrant. Very useful also in non-trauma patient, and I have found it useful in the last few years. I saved at least probably 3 young ladies' lives because of ultrasound, because of the right decision and the right time and right treatment. And this is really crucial to have this skill. That's basically this lady. She was 31 years old. She came. She was treated for septic gastroenteritis, but she had actually ruptured ectopics. It took me less than 30 seconds what the problem was. The patient was already in the department for 4 hours, and she was in resus. And when I went, they called me because the patient was deteriorating, and ultrasound, Morrison's pouch, and then that was basically the video clip I had. And while I was talking to the patient, could you be pregnant? Put my probe, and then I know what the problem was. And in 5 minutes, she was out of the department to the operating room. The pipes, or high map A, aorta, and obviously we're just looking for abdominal dissection of the aorta. That was in a patient. Unfortunately, he died because we delayed. We didn't recognize that he has got ruptured aortic aneurysm. And by the time I was involved, patient was passed away or arrested on CT. He was having CT KUB because we thought it was a flank pain. And there's a picture of aortic dissection. Because of the time, I will just go. If you advance in your ultrasound skills, obviously, then the pipes, you can look for DVT. What it helps is with, if you've got a patient is going to arrest and you think this is massive PE, and then if you find DVT, that gives you another tool that makes your decision easier to say, now I'm sure this is massive PE, patient is going to arrest, I'm going to thrombolize this patient. Okay, time is going on. There's pulmonary, high map. The lung is always actually with the heart together, but it's on this mnemonic is on the bottom. And this important thing is lung ultrasound is actually easy to learn for certain conditions and extremely useful. Echo can be complicated apart from the basic windows, but lung is for you the beautiful escape tool, because if the heart is not working, you will see lots of B lines, meaning wet lung, and you will see pneumothoraces, you will see pleural effusions, pneumonias, and so on. Time is running. This is a picture, video clips. One is normal where the pleural sliding, the other one, there is no sliding in a respiratory failure patient. And that's one picture again, pulmonary edema. Then we can look for effusions, and this is fully consolidated lung. Okay, I was just going to talk about the evidence, but I think my time is run away, now out. I'll just do a summary, and we just finished. I'll just do summary. There are these pictures you have
You
seen.
can speak for 2 more minutes, no problem. You can speak for 2 more minutes.
Okay. There are other cases, but there is no time. As a 15 minutes, unfortunately, very short. There are lots of cases there. To summarize, ultrasound really will or can help you in managing critically ill patients, especially with undifferentiated shock. And what Our President, Professor Bashar Jandar, also mentioned, I heard him a few times, making the right decision, right diagnosis, and right treatment in timely manner, because time is crucial if your patient is very sick. If you want to save this patient's life, you need to use all your clinical skills and everything available to you. But the ultrasound is extension of your clinical skills. It is unbelievable tool if you learn it. And if you practice, if you basically then become competent on it, it just will save lives. And especially if your patient is very sick and you need to make a right decision. I've got lots of cases and where really ultrasound made definitely different, and I'm pretty sure in certain cases it may have ended up very badly. Any questions?
We'll take the questions at the end.
Yep.
We'll take the questions at the end.
Okay, yeah, that's no problem.
Yeah. Thank you.
Bye.
The next speaker, it's always a pleasure to introduce Errol. He's a mentor for many people, like Professor Bashar Chander is there. He will be speaking about the role of point-of-care ultrasound in resuscitation.
Yes. Good morning, everyone. I'm very glad to be here after so many years, and I feel that I am giving my first lecture, as I am giving my first lecture because of 2 years period, 2 years gap, and really I am happy to be with you. And also, I would like to thank my Professor Bashar Jandar to invite me and accept me in his team, and also Dr. Srinath Kumar for his great invitation. Thank you. Today's topic is the use of ultrasound in cardiopulmonary resuscitation, use of POCUS during CPR. It is a very hot topic, but not like COVID. Really hot topic in the last 10 years. This is my lecture plan. I will talk about the milestones for POCUS in emergency department. And then after that, when and how you use ultrasound during CPR, arrest patients. And I will talk about the role of POCUS in cardiac arrest. A little bit, I will talk about the conflicting studies about the POCUS using CPR. And I will give some practical recommendations for your performance of POCUS during CPR. Really good recommendations. And I will try to sum up the lecture. As all we know that the ultrasound come to the emergency world during 1970s and emerged from the German trauma surgeons. Dr. Zeki knows better than me because he was there during this period. And they did ultrasound first in trauma patients. And after that, the trauma literature, ultrasound literature grows up, and there will be, there are a lot of guidelines, protocols now in emergency world, like ACES protocols, like Dr. Zeki told, RUSH protocol, FOS protocol, FOCUS protocol. We have a lot of protocols. And after this bulk of literature, American Society of Echocardiography, and also the American Academy of Emergency Medicine physicians sit around that table and release a statement about the use of ultrasound during CPR. And what did this statement say us? That first, you can use echocardiography or ultrasound as a non-echocardiographer or non-cardiac physician, I mean. But you should be well educated, well trained,